I would like to introduce Dr. Michael Jessen, Professor and Chairman, Department of Cardiovascular and Thoracic Surgery, Heart, Lung, and Vascular Center at UT Southwestern to talk about coronary artery bypass surgery in 2016. Welcome.
Thanks very much. It's a great privilege to be speaking here today, and I was particularly pleased this is dedicated to Owen O'Bell, who is a great friend and colleague. This is my disclosure slide. I want to very briefly talk about some updates of things in CABG that occurred over the last 12 months or so. Things including a new trial on PCI versus CABG, some updates on diabetic patients, some intraoperative management issues, and the new guideline issues on secondary prevention after CABG. First, most trials that were done on PCI, comparing PCI to CABG in the past, did not include the second-generation drug-eluting stents, as alluded to earlier. 25% of the adverse events in the Syntax trial were due to stent thrombosis, and this has now been reduced in these new devices. The BEST trial was a randomized non-inferiority trial in 27 centers in East Asia that randomized 880 patients. The primary endpoint was a composite of death, myocardial infarction, or target vessel revascularization 2 years after randomization. It was published in March of this year in the New England Journal. And the patient group is shown here. Of note, on the PCI group, it was all using the newer generation stents, and there's a complete revascularization was about 51%. And interestingly, in CABG, a lot of these patients were done off pump, about 64%, and most patients got bilateral arterial grafts. So the results are shown in here, and once again, the adverse events, the cumulative incidence of adverse events was reduced in CABG, and by 4 years, this was statistically superior in CABG, despite the use of the newer second-generation stents. When they broke this down into the different subgroups, again, it didn't matter what the patient's age was, men, women. Presence of diabetes was particularly a winner for CABG. Higher Syntax scores, greater number of vessels. All, again, the CABG seemed to be better in that situation. You wonder why people do PCI anymore at all when you see results like this. I asked GOP front...
It will change. We will have so much winning if I get elected that you may get bored with winning. Believe me, I agree. You'll never get bored with winning. We never get bored.
And in fact, we never do get bored with winning. It's really quite pleasant. One of the other things we've been winning in, of course, is in the PCI versus CABG comparison in diabetics. And the FREEDOM trial, which is now published almost 3 years ago, showed a substantial improvement in results in patients who are diabetics. A sub-analysis from the FREEDOM trial was published recently, and this compared subgroups which were non-insulin dependent versus insulin dependent diabetics to see if that would determine differences. It's hard to show on this slide, which is actually from the JACC journals itself, but two things came out of this. In patients with diabetes and multivessel coronary disease, the risk of major adverse cardiovascular events is higher in patients who are treated with insulin than those who are not treated with insulin. It's probably that the insulin-treated patients have a worse degree of diabetics, and these are probably sicker patients that do well. They do worse in either arm, CABG or PCI. But in both of those subgroups, the results with CABG are superior over PCI, and the magnitude of that benefit seems to be similar, whether you're treating insulin-dependent diabetics or non-insulin dependent diabetics. That was the results of the sub-analysis that was done there. Another thing that's coming up a lot more now is the use of bilateral ITA grafting. You saw that most of the patients in the BEST trial received at least 2 arterial grafts. And there's been several meta-analyses now that have compared bilateral internal mammary artery grafting with single left internal thoracic artery grafting, almost always to the LAD. The results of this now is shown in there's been a number of trials, but there's a superiority now pretty well established in bilateral internal thoracic artery grafting, and this is a mortality benefit that's shown long-term in patients who get bilateral mammary grafting. I think that this is something that cardiologists should be very much aware of. Surgeons are aware of it, but in the United States, still less than 5% of patients receive bilateral mammary grafting. In our practice, it's about 35% now overall. This is what you should be actually probably demanding from your surgeons, that they do more bilateral mammary grafting. Off pump we've talked about in the past several times. One of the drivers of it, of course, with the way healthcare reform is going, is can it save costs in patients? Even though there have been a number of studies now that have shown perhaps you get less revascularization and perhaps some of the grafts are less durable when they're performed off pump. An interesting study was published actually from Faisal Bakim and his group, which is actually at the VA, but looking at administrative data from the United States in over 63,000 patients, which had compared those that had received on-pump and off-pump coronary bypass surgery. And interestingly, the total cost of hospitalization was actually higher in the off-pump group, and that met statistical significance. So did the number of, the length of stay in patients was also significantly longer, something we don't expect. This is not necessarily the same, you know, in other parts of the world, in India and China, the vast majority of coronary bypass surgery is done off-pump, but they seem to have, but here in the United States, the financial benefits have not been realized. And finally, I want to just review some of the things that came out earlier this year on secondary prevention after CABG. So if you've had a coronary bypass grafting procedure and you're therefore a winner, then you want to have some of the, you want to know what the secondary prevention guidelines are for managing those patients after you've had the bypass surgery. Antiplatelet therapy is interesting. The general trend in this is that we're moving towards greater antiplatelet therapy even after coronary bypass surgery. Aspirin should be administered preoperatively within 6 hours of CABG. And after off-pump CABG, where results may be more challenged, dual antiplatelet therapy should be administered for 1 year, is now a class 1 level of evidence, guideline. And so that in some of these situations, particularly in off-pump CABG, dual antiplatelet therapy has now started to become a reality. In patients who present with acute coronary syndrome, it's reasonable to administer a combination or dual antiplatelet therapy with aspirin and either prasugrel or ticagrelor, which is preferred over clopidogrel, in those patients who have presented with acute coronary syndrome and then get bypass surgery. And as a sole antiplatelet therapy after CABG, which is still the commonest situation, it's reasonable to consider a higher dose of aspirin, 325, rather than the lower dose of aspirin. This is actually parallels the 2011 CABG guideline results. In lipid management, there's a trend now towards high-intensity statin therapy. Almost everybody gets a statin who has the coronary disease that warrants bypass surgery, but now it's recommended as a class 1, level of evidence A, guideline that it should be the high-intensity statin therapies that we should be trying to get in our patients after bypass surgery, particularly those who can tolerate it. Beta blocker therapy should be given to all patients who can tolerate to reduce postoperative AFib. In patients who have a history of MI, they should be prescribed beta blockers, and those with LV dysfunction should be prescribed beta blocker therapies unless it's contraindicated, usually by ongoing heart failure. They should be administered as soon as possible after CABG in the absence of contraindications. As well, ACE inhibitor therapy should be administered after CABG, but there's some caveats here. We should try to get ACE inhibitors onto patients with recent MI, LV dysfunction, diabetes, and chronic kidney disease. And the goal of antihypertensive therapy for CABG is probably in the less than 140 over 85 millimeters of mercury range. Again, this is controversial for all patients right now. But routine ACE inhibitor therapy is not recommended early after CABG in patients who do not have a history of recent MI, LV dysfunction, diabetes, or chronic kidney disease, because it may lead to more harm than benefit and an unpredictable blood pressure response. That's now a class 3 indication in the secondary prevention after CABG. Patients with previous MI and LV dysfunction should get beta blockers, should get ACE inhibitors or ARB therapy, and now also they've added should get aldosterone antagonists, or should be considered for that as well. Patients with bad function who meet the MATE-2 criteria could be considered for ICD therapy, but not until 3 months after coronary bypass surgery to see if reverse remodeling has occurred in those patients. And then this is the secondary, that thing on the top means only a nut job would go against these recommendations. And that's striving to achieve a hemoglobin A1C of 7%, is a reasonable goal for patients with diabetes. Smoking cessation is critical, and counseling should be offered to all patients who smoke. Cardiac rehab is recommended for all patients after CABG. That's a class 1 level of evidence A indication now. And for patients after CABG, it's also reasonable to screen for depression in collaboration with primary care physicians and mental health specialists. Interestingly, although just barely got in, bariatric surgery can now be considered for CABG patients with a BMI greater than 35 if lifestyle interventions have not been resulted in meaningful weight loss. So in summary, patients with complex multivessel coronary disease have better outcomes with CABG than PCI in most trials. Both insulin and non-insulin treated diabetic patients with multivessel coronary disease have better outcomes with CABG than PCI, based on an analysis of the FREEDOM trial. Use of bilateral ITA grafting should be encouraged. The benefits of off-pump CABG are limited, and they may have significant outcome detriments, and cost savings may not be achieved. And for best long-term outcomes, secondary prevention measures should be followed. Thanks very much for the opportunity to present here today.